All right, so today, let's see. Okay, so today we're learning about diabetes. We're going to focus a little, at the beginning, I'm just going to do an overview on the differences between type 1 and type 2 in their kind of acute, unmanaged state. So just some general differences with type 1, they don't make insulin at all. So remember that. That's really key in remembering the difference between 1 and 2. In type 2, they do make insulin, but their body is resistant to it, and that has to do with the amount of adipose tissue that they have. It makes it less resistant, or sorry, more resistant to the insulin that they have. Okay, so the onset of type 1 is mostly in the younger to middle adult ages, okay? So 20s and younger. The type 2 is mostly in the adult, 20s or greater. Now remember that those lines are now being blurred, and that has to do with the increase in obesity rates in kids and adults. And so you're going to see more type 2 diabetes in kids and more type 2 diabetes in older adults, and then you'll also see there's a new category that's kind of emerging where we're having type 1 in older adults as well. Okay, so generally, type 1 is treated with insulin and very frequent blood glucose checks. So they have to check their blood glucose pretty often. So after meals, before meals, when they wake up, before they go to bed. And then they're also controlling it with diet and exercise. So these people have to have insulin. They are insulin dependent, okay? They cannot live without it. They have no insulin whatsoever. What causes that? Well, we're not really sure the mechanism per se or what starts that mechanism. We do understand that it is an autoimmune process, and we're destroying the beta cells in the pancreas that create insulin for whatever reason. There is a bit of a correlation between viral illnesses, gastroenteritis or upper respiratory infections, and then development of diabetes shortly thereafter. And that's in kids, you'll see that. Okay, so in type 2 diabetes, they're not treated with insulin usually first line, okay? Their first line treatment is usually PO medications, okay? And they're doing their blood glucose checks mostly every day, hopefully, if they're being compliant. We diagnose them with type 2 diabetes when they're based off of their A1C and their fasting glucose. So once their A1C, which is a 3-month average of what their blood glucoses have been doing for that 3 months prior, once it reaches above 6.5, then they're diagnosed with type 2 diabetes. We like that blood glucose, we like that A1C to stay under 7. That's kind of hard to do in a lot of type 2 diabetics, and that just has to do with their compliance level and how compliant they are with their diet. Most organ damage, kidneys, eyes, can be lessened quite a bit if we can keep them under 7.5. If they can't do that, if we can keep them under 8 for some patients, we can prevent a lot of complications long term. Okay, so that is type 2 diabetes. Why do these people go on insulin? Well, it has to do with their compliance level and that the PO medications are not managing their blood glucose because they're not moderating their diet. They haven't converted their diet over, they're not changing their diet, and so then we have to keep putting them on more medications to try to control that blood sugar because they're not really doing their part with their diet modifications, okay? So with symptoms as far as when it's uncontrolled or not being treated correctly, they're going to have the 3 Ps. So they'll have the type 1s, they'll have the polydipsia, polyphagia, polyuria. Their wounds don't heal as well. They might show some vision changes as their blood glucose gets really high. The same with type 2s, their wounds don't heal as well. Well, why don't wounds heal very well in diabetes? Well, the problem is that you have too much glucose in the area, and so that glucose is really hard for those healing molecules to wade through, right? So all of our macrophages and things that help clean up the wounds can't really swim through that really thick caro syrup, if you will, because their cells are full of glucose. Now, if they're managing it better, then it's going to be a lot easier for their wounds to heal. Okay. Okay, now with glucose in when it's unmanaged and as far as DKA goes, so there's a little bit of a common misconception with DKA, and we think in healthcare that DKA has to do with the glucose level. So anybody above 400 is considered DKA. That's not true. DKA, the diagnosis of DKA, is not based off of the blood glucose. Okay, I'll let that sink in. So DKA is not based off of blood glucose number. It is based off of your anion gap, the presence of ketones in the serum, the symptoms that you're having, and then your pH and how bad your metabolic acidosis is, as related by the anion gap. So, for instance, someone could be in DKA with a blood sugar of 400. Someone could not be in DKA until their blood sugar gets 500. Some people I've seen in DKA with a blood sugar of 300, in the 300s. So it's not dependent on the blood sugar number. Okay, now with uncontrolled blood glucose in type 2 diabetic, they get the hyperosmolar, hyperosmotic, hyperglycemic syndrome. Okay, and that is the HHS, and that is a set number. It's usually when their blood glucose hits above 600, because these guys are not in metabolic acidosis because they are creating insulin. They're just resistant to it. All right. So labs, as far as labs, when their glucose is untreated or the diabetes is untreated, their glucose will be high, their serum osmolarity will be high, right? Because in the serum or in the blood is going to be a really high concentration of ions, and so that is what osmolarity is looking at. Our pH will be low because we're acidic. We're going to be in metabolic acidosis. Why are we in metabolic acidosis? Well, the product, okay, so if you have no glucose to break down, no carbohydrates whatsoever, right, and they can't break down glucose, so they're intaking it, but their body can't do anything with it because they don't have insulin to bring it into the cell. So if that happens, the body automatically goes to breaking down fat. And the byproduct of fat breakdown is ketones. So that's why they make tons of ketones. Well, ketones are acidic, and so then that creates our metabolic acidosis, okay? So these guys are going to have similar lab results, except because they still make insulin and they're still able to use glucose in some way, they will not be in metabolic acidosis. So our type 2 diabetics can't be in true metabolic acidosis when their glucose is out of control. All right. If no treatment, like I was saying, we have diabetic ketoacidosis. If no treatment in group type 2, then we get the hyperosmolar hyperglycemic syndrome. Okay. Of hyperglycemia in both of these groups before treatment. So they will have a change in their level of consciousness. So will these guys. They're going to have hot and dry skin when they're hyperglycemic. So hypoglycemia is where you see the cold and clammy skin. Okay. And then their blood pressure is going to go down because of massive hypokalemia. And then our appetite will change. You will probably have some symptoms of nausea and vomiting. They're going to be weak, tired, general malaise. And then their respiratory rate is going to increase. Why? Well, because the metabolic acidosis, and we're trying to get rid of all those ketones. And so what happens is we have an excess of hydrogen ions, which is the acidic component. And so then our respiratory system, which is coming from the kidney, so then the respiratory system has to compensate for that and try to blow off some of that excess acid by blowing off CO2. So we change our respiratory pattern over to kussmaul respirations. This is where a lot of healthcare professionals get a little bit of a misunderstanding. They think that it's fast and shallow. The respiratory rate with true ketoacidosis is fast and deep. So it's called kussmaul, and that is fast and deep. So they will be breathing in and out their entire tidal volume. So very fast, very deep, okay? So not a fast and shallow, but fast and deep. All right, now these guys have all of the same, except they don't have a change in their respiratory pattern. Why? Because they are not in metabolic acidosis. They don't have an excess of hydrogen ions because they're not breaking down fat. They're not making ketones. So they are making some insulin, correct? And the cure for diabetes type 2, the relative cure, is to obtain a normal BMI by losing weight and controlling their diet, controlling it with diet and exercise. You can essentially almost go off of all of their meds and with diabetes type 2. Okay? A little bit about the difference between the cell and the serum before and after treatment. And so this kind of helps you, people kind of internalize what's going on in like that osmotic gradient. Okay, so in Mr. Cell, before, now both of these are before their treatment for DKA, okay? So they don't have any insulin whatsoever in their cells, they have no insulin whatsoever circulating. They don't make it. Therefore, there's no glucose delivery guide, okay? So in the cells, there's no glucose and there's no potassium, or very little. All right. Insulin is the Uber driver that takes the glucose from the blood or the serum into the cell, otherwise known as, go with me on this one, in, cell, in. So it takes things from the blood into the cell. Okay? Now, in our serum, it's going to be the opposite. Before DKA treatment, we're going to have high potassium. We're going to have high glucose, obviously. Okay, because the potassium is going to follow the glucose. All right, there's no glucose delivery guy, right? Like we talked about it. Where's the greatest concentration of ions? It's in the serum, not the cells. So that's where all of the potassium and the glucose are. Therefore, everything is going to follow. And so our greatest concentration of ions is in the blood. Now, after treatment of DKA, this is what we have. So in our cells, now because we have the glucose delivery guy, whose name is insulin, right? Now we're going to have glucose in the cell and potassium in the cell. But then reflexively, over in the serum, our potassium is going to go down and our glucose is going to go down. So we really need to monitor our potassium pretty closely along with the glucose. And that's because we have our delivery guy, aka insulin, in cell in, okay? So this is also why we want to change the patient over to hypotonic. We want to change them over to hypotonic fluids. So that's our half NS, okay? And why do we want to do that? Well, if we give them hypotonic fluids, then it will keep the cells from lysing, okay? So that hypotonic fluid is going to be delivered into the serum, thereby lowering the concentration of ions, and so then it will keep those cells kind of happy, a little bit fuller, because then the greater concentration of ions will go to the cell and not to the serum. Okay, so it keeps those cells from lysing. All right, now, so do the diabetic type 1s. This is a really common misconception with healthcare providers and with patients that are diabetic type 1. So do they need insulin if they're not eating? Yes, it's a resounding yes. They have to have insulin even if they're not eating. Now, mind you, it's going to be a lot less insulin, but they still need it, okay? Because the liver is always, always, always making a little bit of glucose, having gluconeogenesis, because our brain and our basic body functions need glucose to work. So if we're always making glucose, that means they need to continually be taking insulin, whether they're eating or not. Now, if they're sick, a lot of patients think, oh, if I'm sick and I don't have an appetite, I don't need to give myself insulin. That is not right at all. And actually, you might need more insulin when you're sick because of that cortisol release from the adrenal glands, which increases our gluconeogenesis from the liver and then makes our blood glucose even higher than it would if we were not sick. So even if we're not eating, the liver is still producing glucose, releasing glucose, and then when we're sick, even more glucose is released. So we really need to stress this with our diabetic type 1 patients. Even if you're not eating, check your blood glucose and dose yourself with insulin, okay? Especially when you're sick. All right, let's talk a little bit about our acute treatment and why we do things in this order. So the first thing you want to do is just give them IV fluids. Why? Well, because they're dehydrated. And also, if we can dilute that glucose down a little bit, that will help as well. Okay? So we give them LR or NS to start out with. So here we're doing isotonic fluids, okay? And then possibly we're going to need to change that to half NS. And the reason why is because we want a hypotonic solution so that when we give them fluid into their serum, we can drive some fluid back into the cell, okay? Because if we decrease the concentration of ions in the serum, we can now change the gradient and move fluid back into the cell. This will also prevent our cells from lysing, okay? So we want to do that. Okay, now, our insulin bolus is IV push, okay? So first we're going to give them a bolus in the form of IV push. Or you can do it on the pump, either way. But most of the time you don't have your insulin drip prepared yet because it has to come from pharmacy. And so this is what you can do immediately per the provider's order to control their glucose like right then and there. So we give them an insulin bolus, IV push, and that's 0.15 units per kilogram. That's how it's dosed, so it's weight-based. This is regular humulin. So regular insulin, which is known as humulin or novolin, okay? It works for about 4 to 6 hours, okay? This is different than Humalog, which is the really quick acting, or Novolog, so the logs are quick. They're 30 minutes to 2 hours. Now Lantus is the extreme other end of long term. And so it works for 24 all the way as much as 36 hours. So in this patient, we're going to give them a bolus of IV insulin, IV push, okay? And that is 0.15 units per kilogram. Now we're going to turn on a drip because we have to keep them at a rate, and we're trying to slowly decrease their blood sugar very, very slowly. And so that's where the drip comes in. So we put them on an insulin drip, and this is dosed in weight. So you cannot go in the pump and set it up based on volume. This is where you actually have to use a dose. And that's 0.1 units per kilogram per hour. That will be how fast we run it. So the concentration of the insulin drip will always be 1-to-1. So that makes it really easy and nice, right? 1-to-1, so 1 unit for every 1 milliliter, which means when you go to calculate it out, it's the same drip rate in units as it is in mils. So you don't necessarily need to convert this over to mils per hour. You can just say units per hour, and it will program the exact same on the pump. Now, when we have our electrolytes, this is where I was talking about when we were talking about Mr. Cell and Mr. Serum. We need to really closely monitor potassium. Because once we start giving insulin, that potassium is going to start coming down nice and easy. But the problem is we don't want it to come down too fast, and we don't want to make them hypokalemic. So we start treating them with IV potassium when their potassium dips below 5. And now you're going to think, wait a second, Genevieve, when potassium is between 3.5 and 5, that's considered normal. Yes, it is. But when we are treating a DKA patient, we have to start giving them potassium preemptively as a preventative. When their potassium goes below 5, we need to start giving them potassium, right? So our potassium before insulin is very elevated. Potassium after insulin is way decreased, and I'm talking about in the blood, okay? All right, now our blood glucose levels. So at this point, you're gonna have to change their fluid, right? So we changed them to half NS now, from NS to half NS. Now you're gonna have to add potassium to the fluid. Depending on how low that potassium is, the provider is now gonna have you change the fluid again to half normal with potassium. All right, now, once our glucose dips below 250, we don't want them to get too low, right? And we don't want to do it too fast. So then we might change the fluids to add D5 half NS and also decrease our drip rate of our insulin by half. So our drip rate before was 0.1 units per kg per hour. We would probably change it to 0.05 units per kg per hour. Okay, so that's how that change would go. And then we want to watch our pH and give bicarb when pH starts to dip below 6.9, although that's not necessarily compatible with life, but that's when they would start thinking about giving bicarb. Our blood glucose checks, we're going to have to do them every 15 to 30 minutes. 30 minutes is kind of the limit of how long you want to go before glucose checks on these people that you have a drip on them. So because we don't want to decrease that blood glucose too fast, and everyone responds a little bit differently to insulin. So that's why you want to really watch them. We don't want to decrease them more than 100 points in an hour. 150 is kind of that upper limit. And this is because that if you do it too quickly, you can cause brain swelling, and someone can actually just straight up swell right out their foramen magnum. So we don't want to do that. Our blood results before treatment. So you're going to expect that the serum osmolarity will be really high because we have a high concentration of ions, again, because we have so much glucose in the blood and a lot of potassium. Our BUN and creatinine are going to be high, and that's because the kidneys are in trouble. They're having a hard time processing all the ketones and everything, and the glucose that's being delivered to the kidneys. The potassium is going to be high, right, because it's going to stay with the glucose in the serum, and there's no insulin. So it's not going to get transported into the cell either. Our hematocrit is going to be high because we're dehydrated. And so then our CO2 is going to be low, and that's because our respiratory system, we're breathing off that excess CO2. And then ketones and acetone in the blood, I'm talking about in the blood. Okay, this is something that's checked in DKA is the acetone or ketone level. And because the byproduct of ketosis or fat breakdown, right, because we can't break down the carbohydrates because we're trying to break them down, but we can't actually get them into the cells. So then the body turns to fat as a source of energy, and the byproduct of fat breakdown is ketones. Okay? So that's why the keto diet, that's the reason for the keto diet. But you have to remember, with people that are on the keto diet, they're not diabetic, and they're still able to process and deliver glucose into their cells. And then they are also intaking some carbohydrates. So in foods that are low in carbohydrates, they still have carbohydrates. Okay, now our pH in our blood is going to be low because we're in metabolic acidosis. Our bicarb is going to be low because we're in metabolic acidosis, which is why the CO2 has to decrease. We're trying to blow that off to try to compensate, and so then we'll have some respiratory compensation for that metabolic acidosis. So in the urine, you're going to have a high specific gravity in the urine, and this is late into DKA. So in the beginning, they're going to be peeing out tons and tons of diluted urine, but then now they're in full-blown DKA, and they won't really have a lot of output, and the output that they do have is going to be super concentrated. And so they're dry, super concentrated urine. Our ketones, because the kidneys are trying to dispose of that byproduct of adipose or fat breakdown. And then our protein levels are going to be high because in the urine because the kidneys are in trouble. And then our glucose is also going to be really high in the urine because here again, the body's trying to get rid of glucose any way it can because it can't deal with it. It's getting too high, and so then you just start peeing it out because you have no insulin. All right, and that is the end of the video.